Okay. Okay. So that's my hospital in outskirts of Delhi, in Gurgaon. We have 10 cardiac theatres and 300 intensive care beds. So one myth is ECMO is the same as a cardiopulmonary bypass. What we do for cardiac surgery? Well, it is not completely correct because it's used for a much longer period of time. I will not get into details of that because you had it all day. You have been discussing those things. And these are the circuit parts of the circuit which are required, but it's a little, since it's used for a longer period of time, the oxygenator is special, the pump is special, because earlier days, oxygenators, we were using bubble oxygenators, which no more are used. It's a little bit different than cardiopulmonary bypass. All this you've gone through already, the hands-on outside, I could see that. Can you put it in the full screen, please? I think we're getting that. Okay, yeah, but it's blocking the part of it. So these are the circuits which you already seen. One myth is patient needs to be paralyzed and fully out, sedated. Yes, that is correct when you're starting the ECMO. Okay. So initially, obviously, you need it. You don't want the patient to be thrashing around when you're inserting the cannulas and all. But yes, patient can be mobilized. Once they're comfortable on it, they can be conscious. They don't really need to be sedated unless you need to sedate it from the ventilatory point of view or from some other point of view. The patient can be mobilized on ECMO. It is also, as I said, is being used as a bridge to transplant. So obviously the patient cannot be kept sedated and paralyzed till you wait for the transplant or the heart to arrive. Other myth is that ECMO can be put only by the cardiac surgeons. Traditionally, that was what was thought, that it is their forte, it is their domain, nobody else can interfere, which is not correct, because now most of the VV ECMOs are being inserted by intensivists or VA ECMO. You do need vascular access. If you're doing inserting it in cardiac surgery, yes, cardiac surgeon will put it. Otherwise, you just need a vascular access. Actually, I have put VA ECMOs myself without any surgeons. Help and paramedics also have been putting VV ECMO in the ambulances, in the air ambulances. So it's not reserved for a particular group of people. And ECMO, other myth is it can take over the function of the heart and the lungs, which may not be correct, because partly you can buy time till your heart and lungs are recovering, whichever organ you are trying to support. But nothing can really, God has created such a wonderful organ that nobody can really completely imitate that. Here you require a power backup, you can have other complications which you normally don't see with the heart. And there can be complications like there is extra devices going inside the infection, thrombogenicity, heart and vessels are not thrombogenic, you don't need to take heparin or anticoagulation when your heart is beating on its own. This thing is ECMO is only for respiratory therapy, which it has actually is quite useful in recent times, particularly in the New Zealand, Australian large studies of H1N1 influenza. It has saved many, many lives. And obviously you must have gone through the CESAR study. Dr. Bhavani has been actively involved with the Leicester group of the hospitals where it was the study was done from all over UK, and it did show mortality benefit. More than that, it showed the feasibility that you can transfer a patient from one part of the country to another part of the country and save a lot of lives. And suddenly it picked up in India also. It has become a bit H1N1 influenza came in, so this was written up in different newspapers of what is ECMO. It takes over the function of heart and the lungs. The indications you've already gone through, so I will not repeat that. Refractory arrhythmias, PE, and it has been used. See, conventionally sepsis was not an indication for ECMO. It was a relative contraindication, but there are several case series of ECMOs used in septic shock. Then the other myth is that ECMO can be initiated in the operating room or in the ICU, both. It can be, although it has been inserted in ambulances, in the air transport, so that is what the paramedics have been doing, outside India at least. Then ECMO gadgetry is bulky. Well, now everything is being miniaturized. So ECMO now for transport, you have much smaller equipment. The oxygenators are small. The centrifugal pump is small. The tubings are not too cumbersome. Then the next myth is that ECMO is useful if surgical correction is inadequate or pathology is untreated. Now, ECMO is only a bridge to the pathology being reversed, either surgically or if you are talking about LVADs or heart transplant and things till that is achieved. So if a surgical correction is not properly done, then ECMO is not the solution. The heart needs time to recover, but the surgical correction has to be proper. You cannot have a partially revascularized heart and hope that ECMO will take care of that. And the pathology has to be reversible. Obviously, that's an indication for putting in ECMO. You do not put it when there's irreversible pathology of the heart or the lungs or the patient a terminal malignancy. And ECMO is as uncomplicated as cardiopulmonary bypass. That is another myth. It is not as simple as that. Complications are more. Cardiopulmonary bypass is the simplest thing. Things are under totally controlled conditions. Patient is nicely draped and everything is planned. So complications on ECMO are more than what you see in cardiopulmonary bypass. The complications may be patient related, may be circuit related, and the complications can be quite devastating. Thromboembolism, bleeding, and sepsis. These are the three biggest complications. Limb ischemia is another one. So obviously you will have distal perfusion when you put in an arterial cannula. So this is the percentage, pretty high percentage, you can see that, of complications, particularly in cardiac VA ECMO. And then the other myth is there is no database. You have, if you look at STS, Society of Thoracic Surgeons, American Thoracic Surgeons Association, they all have their databases. But yes, ELSO registry is quite alive and kicking. There's a good amount of data from worldwide, although India needs to contribute a bit more to the numbers of ELSO registry. So many of you would listen to this in January conference which we are holding in Delhi. The next is ECMO's initiation is followed by high-end antibiotics. Like in India, the concept is patient goes on a ventilator or patient comes to ICU, you have to load him with half a dozen antibiotics and antifungals, which is incorrect. Some of the pediatric centers actually do not even routinely give antibiotics in the West. Yes, your sterility has to be very stringently maintained because sepsis can be a problem in intensive care units, so patient has to be isolated, a nurse everybody has to exercise proper hand hygiene discipline, and initially you can start with low-end antibiotics. Only if required, you may give higher antibiotics. Otherwise, if you're inserting ECMO, you just need 1 or 2 shots of antibiotics like a surgical procedure when you put it more for gram-positive cover than gram-negative cover. And then ECMO insertion is a terminal event. Well, 25 to 30 years back when I was training, it was the concept that the patient who goes on a ventilator, that means you might as well start getting the death certificate ready, which is not true. That's why it is important to all these invasive techniques, including ECMO, should be inserted in time, because multiple studies have shown that once your end organ failure starts, multi-organ failure sets in, mortality will increase exponentially. So you should put it in before organ failure starts happening. And 5-year results of 219 consecutive patients, refractory post of cardiogenic shock. Now, cardiogenic shock also has about 30-40% survival, actually, when VA ECMO is used. And as you can see, this must have been discussed earlier. Mortality can be quite low in neonatal, reasonably low in pediatric, and not so bad in adult ECMOs. Obviously, the VA ECMO is a higher mortality. That means the cardiac ECMO than the VV ECMO, which is a respiratory ECMO. And this is the ELSO registry ECMO results in 2009. Fairly good survival, but more complex the procedure, more complex the pathology of the heart, lesser the chances of recovery. So how to improve the results? With surgical correction, no residual defects should be left, and heart should be supported and rested. The lungs and heart should be supported and rested during that period. So as I said, end organ damage should be prevented. And the second other myth is that ECMO has no learning curve. As typically many of us believe, you see one, you do one, and you teach one, which is not the right way to go about it. One of the studies had shown that you require about 10 to 20 ECMOs before you become comfortable and safe to do it independently. So take help from people who have been doing it regularly, at least for the first few cases, before you start doing it on your own. Other myth is the cardiac ECMO should be initiated when post-op problems happen in ICU, which is not correct because already the damage is happening during that period. So earlier you put in the ECMO, the better it is. So ECMO, when it is started in the operating theater or a VA ECMO, and it started in the post-op period, you can see the survival is much better when it is put earlier in the operating room rather than in the intensive care unit when the patient has crashed. Other one is ECMO needs a lot of blood and blood products. Well, it's not really a myth, but it may be a bit exaggerated because Jehovah's Witnesses also have been undergone ECMO. So you can manage, if you're careful, with other blood preservation and blood conservation techniques. As I said, H1N1 was a good thing. A lot of lives were saved in Australia and New Zealand, and there was consumption of blood during that phase was about 1 unit per day, which is not a huge amount of blood. This was an Canadian study, H1N1 respiratory failure. Now these are the complications which happen, which already you must have been discussing today. And these are various blood conservation techniques which are available. You can cut down significantly your consumption of blood and blood products because that not only increases your morbidity and mortality, but also, as Dr. Pubani was saying, a substantial cost later on after you initiated the ECMO are the blood and blood products which will happen. So recombinant factor 7A also has been used, but again, it's an extremely expensive modality. ECMO is too costly. Dr. Pubani has already talked about it. Well, it all depends on how much the hospital is charging for its overheads, but at least initial cases, when you start off, you have to subsidize it and modify your techniques accordingly to cut down the cost. Most of the cost, as I said, is blood and blood products, high-end antibiotics, and intensive care. So earlier you put it, the better it is. Proven it.